We'll move on now to our next speaker, who is Dr. Deepti Gurdasani. Dr. Gurdasani is a senior lecturer in clinical epidemiology at Queen Mary University in London. Dr. Gurdasani will be talking about epidemiology, vaccines and spread. Over to you, Dr. Gurdasani.
Thanks. Can everyone see my screen? Yeah.
Yep.
Okay.
Yep.
I have a rather long presentation, but what I'm going to do is quickly go through the top line of the key messages that I wanted to share today. And I'm very happy to go through any details around specific slides or evidence later on if anybody wants to. My contact details are at the end of the presentation. So I just wanted to have a look at where we are now and the potential pathways from here. So this is a situation update for the whole of the UK. We've had over 140,000 deaths from COVID-19 registered on the death certificate. We are quite high in terms of global deaths in a comparison to the rest of the world. We have hundreds of thousands of people estimated to be living with long COVID in the UK. And while the daily infection rate is coming down, we need to remember that the overall infection rate is the same as it was in September when SAID suggested a circuit breaker lockdown in England. So the Office for National Statistics data shows us that while that declines have happened, which is very good to know, these declines are plateauing, and we particularly see this in Scotland, which is a slightly worrying trend that we need to keep an eye on. So that was the ONS data. That is a survey that looks at asymptomatic and symptomatic cases. But when we look at our symptom-based testing from Public Health Scotland and Public Health England, this is the Scottish data. Again, we see the same plateauing of declines in cases. And here I want to talk about a place where the Scottish strategy, I feel, has gone wrong. There has been a myth in Scotland, perpetuated, I feel, by scientific advisors as well, that schools don't drive transmission in the community, and particularly primary schools don't drive transmission in the community. Unfortunately, much of this rhetoric has relied on flawed data, which is based on symptom-based testing in children. We know that children are far less likely to be symptomatic compared to adults, and when they develop symptoms, they're likely to be atypical symptoms. And this is just to highlight how much we can underestimate cases in children. This is actually a study from Mississippi that shows that if you compare seroprevalence data, which is antibody data, with actual reported cases, there's a 68-fold underestimation of the number of cases in children. And we see this in our data in England as well. So one thing I want to highlight here is this is data from the Office for National Statistics. So it doesn't suffer from these flaws. It's not based on symptom-based testing. And the age groups that I want you to look at are age 2 to school year 6, which is the red line, and the orange line, which is secondary school age groups. And if we look at when schools open, and when schools open, particularly when lockdowns end, we've seen rapid rises of cases in school-age children at points with school-age children having the highest rates of infection across all age groups, which is something that was never captured in symptom-based data. And also, you see that peaks based on childhood transmission, so peaks in children, which are these two groups, often happen prior to peaks in the community, suggesting that that they do actually really drive community transmission, because rise in cases among children, if you really measure this properly, predates rises in the community. And just to show a contrast with our symptom-based testing data, where this is never apparent. So here's the yellow line, which is sort of primary school children, and the gray line, which is secondary school children. And you never see these patterns of higher prevalence in other age groups or them predating community transmission in other age groups if you just look at symptoms, which is the data we have unfortunately been looking at in Scotland. And if you actually do household contact studies using these data, which focus on all infection, including asymptomatic infection, you see a very different pattern to what people have been claiming, which is that children, both primary age and secondary age school children, are much more likely, so between 2 to 7 times more likely to be the first case in a household bringing infection in. And when they bring infection in, they're 2 times more likely than adults to transmit to their contacts. And if you want to look at it another way, which is potentially less biased, if you want to look at risk of infection among teachers, this is a study from Sweden where there was a sort of natural experiment in that lower secondary schools were open for in-school teaching while upper secondary schools were closed for in-school teaching. And what we see that is that teachers were at twofold higher risk of infection when they were undertaking in-person teaching versus remote teaching. Similarly, we see parents of children in school teaching were at about 17% higher risk as well. This risk was so high that it even spilled over to the partners of the teachers. And we see similar data from England as well, where the recent React 1 survey shows that those in teaching occupations are about 40% more at risk of infection compared to those in non-teaching occupations. And this was during a period where schools were only open in a limited manner, so they weren't even fully open. And here's another large study from Denmark in about 500,000 people that again show that your risk increases with the number of children in a household. It does increase with age, but you see that there is increased risk even if you're the parent of a primary school child. And I do want to say that Denmark has quite different measures to the ones we have in place in schools. So in spite of that, and if you look at global evidence, it's very clear that school closures are one of the most effective interventions in bringing down the R rate, or the rate of growth of the pandemic. And if you look at it in more detail, you don't see much of a difference whether it's school closures of preschool settings, primary school settings, or secondary school settings. They both contribute a lot to transmission and to R. I guess the big question is, do mitigatory measures help? And this is a large study from Johns Hopkins, again, looking at around 500,000 parents of children in education, and again shows that parents of children in education are at higher risk, even those of children in younger age group. And what we find here is, although this is symptom-based testing based, so we need to remember even this will underestimate risk, we find but hopefully not that much risk in parents, which is what we're looking at here. We find that mitigatory measures do reduce the risk, but it's not just one or two measures. What we need is multi-layered measures. The more measures you have, the more likely that you can bring risk down to baseline. And all of this is far more complicated now that we have the new B117 variant, which we know is far more transmissible and potentially even more fatal. And with this variant, we're now seeing large outbreaks, particularly in primary school and daycare settings in different parts of the world, including in Israel, Denmark, Italy, even in the Netherlands. We're seeing that this age group is starting to predominate the proportion of cases. And we need to remember that in our last lockdown in England, when schools were open, these new variant cases were rising with an R of 1.4. Versus the old variant where the R was below 1. So this makes it even trickier to sort of keep schools open without seeing those surges in cases, unless we put in very strict mitigations in place. So this is very early data from Scotland. And this is the point in time where schools were open. These are sort of different age groups. You can see 0 to 14 years here. Unfortunately, I don't have the breakdown by school age, which has not been provided. But we saw slightly worrying increases here, and potentially in 25 to 44-year-olds, which could represent parents. Not sure what this means yet, but looking at this slide, which essentially just takes the same data and looks at proportion of cases by age group, it looks like the proportion of cases that are explained or represented by 0 to 14-year-olds has been increasing. And we need to keep a close eye on this over the next few weeks to really understand what's happening here. And of course, I hear a lot about how, let kids be kids. But the problem is that kids can't be kids when we have to close schools because we don't have safety measures in place and outbreaks occur. And also, there is long COVID, which is being ignored in children. We know that 12% of primary school children and 15% of secondary school children from the Office for National Statistics data, and these are children with asymptomatic mild symptoms as well, not hospitalized children, have at least one of 12 persisting symptoms for at least 5 weeks. And we don't know the impact of this on children yet. This is a study very recently come out in 500 children based on a survey of children with long COVID. And the symptoms can range anywhere from severe fatigue to neurological symptoms, which are really worrying. And we see these in adults as well. And for people who think this is short-lived, in this particular survey, the average duration of these symptoms was 8 months. So we need to remember that it can be hugely debilitating when it occurs, and we don't really want to expose children to risks that we don't even understand yet. And I just want to put this up there to say that SAGE actually warned about this, at least in England, when schools were opening up, saying that opening even just primary schools would lead to R rising to 1 or above 1. And with the reopening strategy that we have in England, even with vaccine rollout continuing at the current rate, we would have at least 30,000 additional deaths from here on. And this brings me to the biggest myth of all. We are vaccinating people, so we don't need to worry about any of this now. This simply isn't true. And we have a strategy that's largely solely focused on vaccines as the way out. And there's a lot of uncertainty about this. One, can we even eliminate through vaccinations? This is a chart showing that even if there was 100% uptake of vaccinations among people who are eligible, because a large part of the population isn't eligible, particularly children, you still may not have enough effectiveness in terms of reducing transmission to reach our herd immunity threshold or to bring the pandemic to an end. And there's even more uncertainty because vaccine uptake isn't going to be 100% and actually going to vary very likely by deprivation and by vulnerability and by ethnicity. And of course, we don't know the duration of immunity. We know now, looking at Public Health England and even some data from Public Health Scotland, that vaccine effectiveness for preventing symptomatic disease may be potentially lower in over 70s after the single dose. So they need 2 doses for full protection. So we may have a large population post single dose of Pfizer. This is not a problem with AstraZeneca, only with Pfizer, who are potentially more vulnerable to severe infection until they receive their second dose. So while we're rolling out vaccines, there's a huge potential for many more cases to occur, for R to rise above 1, many more cases of long COVID and deaths to occur, which has clearly been modeled. And to think that just because we vaccinated a proportion of the population, be it a larger proportion of the vulnerable population, we won't see this is not true. And of course, there's even more uncertainty now with vaccine adaptation. What is the vaccine effectiveness against new variants that are emerging and the duration of immunity against these? So it's very clear that we need to keep transmission down alongside vaccination, and vaccines cannot be our sole way out of this, however important they are. And this is talking about the comparison of Scotland and England. And in England, we've had a strategy that's clearly tolerable deaths and living with the virus. It's been articulated by our CMO, which essentially leads to between 30,000 and 80,000 acceptable deaths. This is baked in. And many more people living with long COVID. Our NHS capacity can still be overwhelmed despite the vaccination that's occurred, because the majority of cases in ICUs are below 70 years of age, and many those above 70 are still not fully protected. And of course, it's a fertile ground for virus adaptation, which creates a lot of uncertainty about our future. So this is just the virus adaptation from Public Health England that we know about so far. And we have at least 8 variants of concern or variants under investigation circulating in the community. Thankfully, most of these are not dominant yet, but even so, we have to keep a very close eye on these, because some of them are potentially very concerning in terms of transmissibility and vaccine escape. And this is a very elegant model that was presented recently that essentially showed that the best way to select for vaccine escape variants is essentially to allow the virus to circulate and transmit while we're rolling out the vaccine. So this is exactly the sort of scenario we need to avoid. So what do we need to do? We need urgent mitigatory measures in schools, including primaries. I know the Scottish strategy, there's been sort of an odd sort of one-upmanship saying it's been better than England because of the staggered starts. But I think we need to remember that staggered starts are not going to be sufficient in preventing those outbreaks and preventing rises in those age groups. They will allow us to observe what's happening for longer periods of time. But to me, putting in staggered starts without putting those basic mitigations in place that are evidence-based and recommended by the CDC doesn't make any sense. And we need to commit to eliminate. It's these sort of yo-yo surges in cases, going in and out of lockdown, school closures that are devastating our society, economy, and children's education. Of course, I think we've heard much more about this from Dr. Rothman. We need to support the most vulnerable through this difficult period. We need good test, trace, isolate, and support systems. we need to reconsider prioritization of vaccines. There's a lot of data out there now that we should be considering exposure as part of vaccines, ethnicity as part of vaccines. All of these things will help us refine our policy with regard to risk and also potentially prevent new adaptation of variants. And we need to remember vaccines are not our way out of this alone. They are part of a multi-layered approach. And we need to work with this alongside in terms of border restrictions to prevent import of new variants and infections. And of course, the problem is this needs to be coordinated. And although, for example, Scotland's border strategy has been much better than England's, it's sort of been scuppered by England's strategy. So unless there's a level of coordination, it's very hard to achieve this. And before I end, I wanted to sort of put this up to sort of show the sort of mitigations we actually need in school, many of which are still not in place in school, even in Scotland, particularly in the primary school setting. And this is an article we recently published in the Lancet that is based on current evidence and CDC recommendations. And these sort of include things like masks, ventilation. I think somebody mentioned previously, a lot of the focus has been on hygiene measures and not aerosol measures. And we really need to bring our policy in line with evidence. And I just want to put up this figure about where we are and where we could be. I hear a lot of arguments against zero COVID saying, oh, it'll lead to long lockdowns, it'll lead to more disruption to life. But this is what's actually happened. In the UK, we're in our third lockdown, 5 months of lockdown and ongoing. In England, at least, we've had 16 weeks of school closures, a year in restrictions. And the picture in New Zealand, and I know we're not New Zealand, but there are many other countries that have achieved this, is very different. Shorter lockdowns, less impact on children, less impact on healthcare, and overall much more benefit to economy and society. That's all for me. Thanks.